Let's go ahead and finish up this chapter with the materials that will be on our upcoming exam and then get into the beginning of the lymphatic system because those vessels will also be on the upcoming exam because they're an important part of the very last topic of this chapter. The next area that we were going to talk about on blood flow in special areas is the skin. Sympathetic stimulation to the blood vessels of our skin will actually cause very definite vasoconstriction. And we do this because we want the blood from our skin. The skin itself serves as a bit of a blood reservoir because we have so many anastomosis there. Very effective this anastomosis is for our heat control purposes, but when we are having a sympathetically dominated stress response, such as when somebody has a heart attack, there'll be very potent vasoconstriction to the skin, a paleness to the skin, and blood is going to be brought to the core for distribution to areas that may be in duress at that time. But these anastomosis indeed are really extensive and are very helpful for our heat control. In other words, a nice radiator effect for us. Lungs. Interesting. When we take a look at the construction of our arteries and arterioles from our heart to our lungs, we'll see that they are very, very thin and flabby. So that's why in our notes it says similar to veins in the rest of the body, because the pressure at the pulmonary trunk is exceedingly low. And therefore, we don't need to toughen up and make a thicker blood vessel going to our lungs. So our pulmonary pressure is 25/10. When you compare that to our systemic pressure of 120/80, major difference. And indeed, a major reason why we have different construction of our right ventricle over our left, as well as the pulmonary arteries versus our systemic arteries. Heart, when the ventricles contract, they will compress the coronary arteries to our heart. This will cause flow to stop during our systole. And while the heart is working, this is basically telling you that the heart is not receiving blood flow, therefore not receiving oxygen, and that's why the heart muscle has a whole bunch of myoglobin inside each cell. And this is going to allow for oxygen storage so that when we are not getting perfusion or circulation or blood, we can rob our myoglobin banks to continue our metabolic activities inside our cells. So myoglobin is an excellent oxygen reservoir. Also, that's another reason why we can do heart transplants, because there's so much myoglobin in that heart muscle, and when we put it on ice and decrease its metabolic activity because of temperature, we will prolong the heart muscle cell's ability to live and therefore function later on in a new individual because of our rich myoglobin reserves. Now we're going to come to that lovely topic that we have a lot of problems with understanding, and that's capillary dynamics. And our notes here state it's blood flow through the capillaries. Before we get into the numbers, this is what I want you to think about. And then after we get into the numbers and the definitions for various numbers, hopefully it will start to make a little more sense. Our cells are always making carbon dioxide and toxins. And in order to function properly, they need to get rid of that carbon dioxide and those toxins, and they need to be supplied with oxygen and nutrients. And so this is done by basically simple diffusion. However, our cells do not get their oxygen needs and nutrient needs directly from the bloodstream. Because remember, blood stays in the blood vessels. So we have to move the nutrients to around the tissues to supply them with their nutrients, and then we have to take from those tissues their waste. The way we do this is we take the fluid component of our blood, the plasma, and we then will allow it to move from inside the lumen of our capillaries to the interstitial spaces. And so on the arterial end of things, when we push that blood, the fluid portion of that blood, into the interstitial spaces, it's full of really good things. And so it will bathe the cells, and then it will allow simple diffusion of oxygen and nutrients into the cells, and simple diffusion of carbon dioxide and waste out of the cells into the interstitial fluid, which has now been kind of supplemented with a nice fluid wave of good stuff. Now, what will happen is we need that fluid now that is now becoming rich in wastes, low in nutrients, to get back into the capillary, and we'll do that on the venous side of our capillary bed. So that's what capillary dynamics is all about. How do we get the fluid out of the capillary on the arterial side, and how do we get the fluid back into the capillary on the venous side so that we can therefore take this back to various areas, various systems of our body to get the reverse done. Nutrients back in, waste out. Capillary dynamics. So with that in mind, now let's take a look at the written notes. Gas and nutrient exchange is by diffusion between the cells and the interstitial fluid around them. So we have to get the stuff into the fluid around the cells in order for it to get into the cells, and also vice versa to get it out. Fluid movements need to provide fresh interstitial fluid for our cells and remove the old. That's what we're trying to do. So we're constantly flushing the system, so to speak, with fluid. Fluid is going to move due to two opposing factors: hydrostatic pressure and osmotic pressure. Hydrostatic pressure is basically, you can think of it as blood pressure. It is the weight of the fluid on the vessel wall that has been augmented by the pushing of the fluid against the vessel wall. And we already know fluid is going to move from an area of high pressure to an area of low pressure. And so hydrostatic pressure, if it's high inside the capillaries, low outside the capillaries, we are going to be able to push some of that fluid out of the capillaries into the interstitial areas. And so hydrostatic pressure is, I will often refer to it as pushing pressure. Now let's take a look at osmotic pressure. Osmosis, we talked about at the beginning of last semester. It had a lot to do with tonicity and things along that line. So it's particles. And so osmotic pressure is due to non-diffusible substances or particles. And most of the non-diffusible substances that are going to stay in our fluid that's going to help to contribute to osmotic pressure is proteins. Proteins won't be moving across our membrane itself. So when we talk about osmotic pressure, because we're talking about fluid moving due to opposing forces, I want you to realize I'll use the term pulls. So osmotic pressure, which is where the pressure is higher because we have more particles and therefore water is pulled into the area where more particles are to quote, dilute up that area and move from an area of high water concentration to an area of low water concentration. So water is going to be pulled towards the area with the highest osmotic pressure, or more particles, so to speak. Hydrostatic pressure is also sometimes called filtration pressure. So we need to talk about the hydrostatic pressure of our capillary bed at the two ends of our capillary bed. Remember, on the arterial end, we want to push the fluid out, and on the venual end of the capillary bed, we want to pull it back in. So let's take a look at the hydrostatic pressure of our capillary bed. And remember that we are trying to push the fluid from the capillary into the interstitial areas. So push fluid from capillary lumen into interstitial spaces. We have already mentioned the pressure at the arterial end of the capillary is 35 millimeters of mercury. And we've already mentioned that the pressure inside the capillary at the venular end is 15 millimeters of mercury. Well, one of the things you also have to talk about when you're talking about pushing the fluid into the interstitial spaces is you have to realize that if there is fluid in the interstitial spaces, it will exert a back pressure. And so we have to talk about interstitial hydrostatic pressure for right now. And it's really kind of strange that most of our interstitial hydrostatic pressure ends up being around 0 millimeters of mercury. So it's almost like saying that there is no fluid in the interstitial spaces. But what is happening, and we'll discuss it as we get closer to the end of this, is there is no fluid buildup in the interstitial spaces. So no fluid buildup. So in other words, the fluid's always being drained off, and if it's always being drained off, we have no excess, and that's where our negative, or not negative, but zero number comes from. If for some reason we had an infection going on, would that interstitial hydrostatic pressure remain at 0? No, because the fluid will build up with all these nasty things inside it even, and that will contribute to osmotic pressure, and so our interstitial hydrostatic pressure numbers will become positive. And this is important because we need to discuss for our hydrostatic pressure, net hydrostatic pressure on both ends. Capillary hydrostatic pressure and interstitial hydrostatic pressure, that is the net. And if we have a nice large positive number, that means we are pushing fluid from the capillaries into the interstitium. And indeed, on the arterial end, capillary hydrostatic pressure is 35. Interstitial hydrostatic pressure is 0 under ordinary circumstances. So that means on the arterial end, our net hydrostatic pressure is 35. So that means we're pushing fluid out by that factor. On the venular end, because our pressure is lower, 15, and again, our our interstitial hydrostatic pressure is still 0 under ordinary circumstances, we will have a fluid push out of 15. Well, that doesn't make any sense because that means that then our fluid will actually build up. And up above, I told you, no fluid buildup in the interstitium. So it's the osmotic pressure that's causing this to not occur. So that's where we're going to go into, because remember, these are opposing forces. Capillary osmotic pressure, what's fascinating is that it is 25 millimeters of mercury on the arterial and venular end of the capillary. So that's nice. We don't have to memorize any numbers. And the interstitial spaces, even though we said there's no net fluid buildup in the interstitium, we do have a little bit of osmotic pressure in the interstitial spaces. So we have some sort of particulates in what little fluid there is surrounding our cells. So we need to now realize, we talked about the hydrostatic pressure pushing fluid into the interstitium. Now let's talk about the osmotic pressure pulling fluid back into our capillary. And that's where net osmotic pressure comes from. Capillary osmotic pressure minus interstitial osmotic pressure. So that would be 25 minus 5 equals 20. So our net osmotic pressure is 20. So now let's do net hydrostatic on arterial end and subtract from that osmotic, because hydrostatic is pushing, osmotic is pulling that fluid back into the blood vessel. Let's do that on the arterial end of our capillary bed, and then let's also do it at the venular end of our capillary bed. So here we go. Add a little more space to this lecture screen field. Okay, arterial end. Well, capillary hydrostatic pressure minus the interstitial hydrostatic pressure is 35. We've already discussed this. That's pushing the fluid out into the interstitium. Well, we don't push out that much into the interstitial spaces because we have osmotic pressure combating that. So 35 minus the 25 minus 5, which is 20, ends up giving us 15 millimeters of mercury worth of fluid being pushed into the interstitial spaces. Now, we want that same amount of fluid to be pulled back in on the venule end of the capillary. Otherwise, we'll end up with fluid in the interstitial spaces, which I told you we don't have, and we'll decrease our intravascular volume if we don't get this 15 back. And so a positive number means fluid is leaving, and a negative number means fluid is coming back. Let's do the numbers at the venule end. Capillary hydrostatic pressure minus interstitial hydrostatic pressure gives us 15 minus capillary osmotic pressure minus interstitial osmotic pressure, which we already stated was 20. That ends up giving us a negative 5 millimeters of mercury. And that gives us a dilemma because that number should have been negative 15. And what this is telling you is that there actually is, and this is an important part of capillary dynamics, there actually is a fluid left over in our interstitial spaces of our capillary beds whenever fluid or blood moves through a capillary network. And so what is going on that will actually keep it from building up? Because obviously it isn't building up. Because if we did have this fluid in there, we wouldn't have our other numbers. And what is happening is that excess fluid that is in the interstitial spaces after we get through the venule end of the capillary bed is being drawn off. And it is being drawn off by the next aspect of our material for our upcoming exam, the lymphatic system. So let's take a look at the lymphatic system for a few moments and see how it plays into our capillary dynamic story. Lymphatic vessels. We have actually little itty-bitty lymphatic capillaries that are interwoven in our capillary bed, and they are designed to return our interstitial fluid that is left over into the circulatory system. So think of these as overflow or drainage vessels. So that's why fluid does not stay in the interstitium. And if you know anybody who's had, for example, breast cancer, and they've had lymph node dissection where they actually interrupted the lymphatic vessel system and blocked that lymphatic vessel return of this overflow, those individuals will experience a problem called lymphedema. So the interstitial fluid indeed does build up and cause edema of that extremity because we don't have the proper lymphatic return system intact anymore. So let's take a look at the distribution and the structure of our lymphatic vessels. First, the smallest are the lymphatic capillaries, and they are, interestingly, blind-ended tubes woven in the interstitium. Our notes state that they're structured like blood vessel capillaries, except the endothelial cells are not joined by tight junctions, and the cells actually literally overlap, and that ends up forming mini valves because they're not knitted together in this area of overlapping. They are literally just overlapping like you would maybe some pancakes on a plate. Also, attached to these endothelial cells are some connective tissue filaments which will anchor the endothelial cells to the cells in the surrounding tissues. And so when we get swelling due to increased fluid, the swelling pulls on the CT and flap area of our lymphatic capillaries, causes opening, opens the space, and allows free entry of fluid and anything that's also in the fluid. As our notes state here, the materials freely enter, so fluid, and if we have an infection in that area, we'll be having sort of cell debris, we'll have microorganisms, we'll have proteins, all kinds of stuff will then be able to actually enter. And that's what this picture is actually designed to show you. It's showing you the overlapping nature of these vessels, their endothelium, and how when you have CT attached to you and you have swelling, which means you're going to pull on that CT, means you're going to open that flap and you're going to allow the stuff to actually enter into those cells. So our diagram for blood and lymphatic capillary interactions, actually it would be really good if you actually drew your own diagram and to show what we have, and I'll pause this recording at the end and I'll put mine up and we'll see what we actually have and compare them. So after lymphatic capillaries, the next larger vessel side is the name is actually just called lymphatic vessels, and they will have same tunics as veins, but already we will have valves. We don't have valves in our venules. These guys will have valves in them, and they will have lots of them. And that's because we want to also have one-way flow. So these valves are like the valves that we talked about in our veins. The next larger size, capillaries, vessels, and now trunks, formed by the union of the largest lymphatic vessels, and will have names now based upon the location that we actually find them. And so these are structures large enough to identify. And if they're in the lumbar area, we'll call them lumbar trunks. If they are draining the intestines, so coming from our intestines, we'll call them intestinals. They even can be associated with our jugular veins, and we'll call those, because of their association, jugular. Ducts are the next largest vessel diameter of lymphatics. They're just two, and they are called right and left. However, the left is also referred to as our thoracic duct. Both of these will empty into the venous system at the junction of our internal jugular and subclavian veins. So right here and right here in our picture. So the right empties into the right internal jugular and subclavian, and the left or thoracic duct will enter into the left junction of internal jugular and subclavian vein. Here is a really nice view of the thoracic duct, and indeed that's why it's called thoracic duct, because you find it in the thoracic cavity. The right lymphatic duct, however, is very, very small and only drains our right upper extremity and right side of head and neck. The thoracic duct will drain the rest of the body, so every place else except for right upper extremity, right side of head and neck, so it drains the rest of the body. And that's because it is coming from below the heart, circling on around and up to get into this junction. And also there are additional trunks coming into it superiorly, whereas the right lymphatic duct only is getting supplied from lymphatics draining everything superior to the heart on the right side. And so that's why we have our head neck area on the right, as well as right upper extremity. Lymph transport is also pumpless, but we have pseudo pumps that actually help fill or not fill, but push the lymphatic fluid throughout the lymphatic system, just like we did with venous return. We have the muscular pump, which remember is muscles contracting, squeezing this valve system, so where blood will actually be milked towards the superior aspect here above the heart. We have also our respiratory pump, that diaphragm causing pressure changes in the abdominal pelvic area as well as thoracic cavity. And indeed, the large collection of valves, more than what we have in veins, is going to ensure lymphatic return. But indeed, because this whole system is truly pumpless, no real pump, it is a much slower system. So we'll stop here and go back to our drawing, and then